Good evening, all the audience who have joined this today's interesting webinar on migraine. So, welcome you all to the webinar, and the today's webinar topic is the migraine, exploring therapeutics option versus latching on the goal. So, by the Dr. Soumyadarshan Nayak, MD DM Neurology from Cuttack. So, this webinar brought to you by DigiNeuro, a digital initiative by Health and You, always together, a joint venture with Nulin Company Limited, Japan. So we as a Health and You fulfill unmet medical needs, launching innovative first time in India products like Amnurite, the first time in India combination amitriptyline plus mycophenolate 5, 10 and 25 mg, pain relief, feeling good, and the better dosage flexibility from Chota Bhim to Bada Bhim. Again, the first time in India combination of amitriptyline plus propranolol SR for migraine when one is not enough, AmnuriteBeta, amitriptyline plus propranolol, and the first time, the first pharmacological combination for neuropathic pain of two neuroanalgesics, that's amitriptyline plus pregabalin, TXR technology. So Amnurite P, it is pharmacological. Again, the only mycophenolate injection which is coming from Japan, manufactured in Japan, the Neurite injection, mycophenolate 500 mcg per ml, the one and only made in Japan, and which is absolutely preservative free, so it is less painful compared to other mycophenolate injections and manufactured under 10 lux light. So offers 100% mycophenolate to your patients. Again, we fulfill the unmet needs. Like first time in India, we have launched clobazam 2.5 mg mouth dissolving tablet. So step ladder treatment of epilepsy. First add clobaz 2.5 mg, 5 mg and 10 mg. The clobazam mouth dissolving tablet, which is in delicious mango flavor and banana vanilla flavor. Add flexibility, add control. Then again, we have launching that. We are already launched in the market the Brentamin vitamin therapy for migraine, the combination of riboflavin plus magnesium and CoQ10 enzyme. So all our webinars are available on our DigiNeuro channel on YouTube. All the webinars, including some neurosurgery and other the therapy like migraine, vertigo, and epilepsy. So I'm very happy to introduce for today's webinar moderator, Dr. Manjusha Patankar. She is a MD in Pharmacology from KEM Hospital, Mumbai. Thank you, ma'am, for coming as a moderator for this webinar. Over to you, ma'am.
Yeah, thank you, Santosh. On behalf of Health and New Therapeutics, we welcome you to this DigiNeuro initiative. The webinar today is entitled Migraine, Exploring New Therapeutic Options versus Latching Onto Old Gold. Our eminent speaker today is Dr. Soumyadarshan Nayak. He is a DM Neurology from SMS Jaipur. He has a headache fellowship from IHS Sydney, Australia. He is a fellow of IHS AAN and several other societies. He is the Assistant Professor, Department of Neurology, SCB Medical College, Cuttack. He was also the ex-associate professor from INS and Sun Hospital, Bhubaneswar, Odisha. So welcome to you, Dr. Soumyadarshan Nayak.
Thank you, ma'am. So should we start?
Yes.
Okay. I think the participation is a little bit less, but we'll start. Anyway, a very good evening to all of you, and I thank Health and You for giving me this platform. And as we all know, that migraine is one of the second leading causes of comorbidity worldwide, and it's usually the young population which is affected, not to mention that the very young children who are affected, including the middle-aged, even elderly. And the incidence is 10 to 13% on both sexes, and it is per 1,000 population. But that's an understatement. With this, I start my talk. But before that, I ask you all to stay safe, stay fit, and stay strong in this time. And we continue imparting knowledge, disseminating knowledge through this visual and auditory platform. So let's begin.
Sir,
as we all know,
excuse me. The
Yeah.
participation is much higher. Participation is through YouTube. What
Okay,
you
okay.
see here is only 5 of us. So it is much
Okay,
higher,
okay.
sir.
Okay, okay, very nice.
Carry on, sir. Carry on, please.
Okay, thank you, thank you. So let's begin. So as you all know, headache is a very frequent condition which most primary care physicians see in their clinical setup. And it's very perplexing. And to know the basic fact, if we have 100 patients of headache, less than 50% come to the physician. Usually they take over-the-counter analgesics. That is what we usually do. We take over-the-counter analgesics, headache gets relieved, we stay back. We never consult the physician. The rest 50%, sometimes they need to come to the physician. And of this 50%, 50% are correctly diagnosed and treated. So that makes it 25%. And of this 25%, less than half, or let's say 50% of it, need to go to the neurologist for a higher treatment or a diagnosis which is not feasible at the primary care physician level. So that's the 50% rule. So 50% don't go to the physician. They take OTC or over-the-counter therapy. 50%, even if they go to the physician, only half of them are diagnosed and treated properly. Why? I'll tell you in my next slides. And of these 50%, less than 50%, that is less than 10 to 12% come to the neurologist for a diagnosis. As we all know, I won't go into the details. Primary headaches constitute 90%. Secondary headaches constitute 10% of our headaches. Whatever we see, 90% are primary headaches, which constitute migraine, tension type, and cluster headache. So all of you know the primary types of headache, but most often you are confused which is a sinus pain, which is migraine, which is tension, which is cluster. Not only you, we are also confused occasionally, whether it's a tension type or a migraine or it's a mix. But let me tell you, the most common cause of headache which you see is migraine. And many a times when somebody tells you, I'm giving you a headache or you are getting a headache, think it is due to migraine. Okay, somebody tells you, I'm going to sing for you 300 songs in lockdown. Immediately you get a headache. So that is migraine. It's not tension type headache. And if somebody tells that I'm seeing some flashes, some lights before my headache, I'm getting some bad feeling, it's migraine. So migraine is very common. Even if they tell that you have some nasal stuffiness, some lacrimation, some unilaterality, it is more likely to be migraine. And what characteristic differs, we will see in the later slides. So how do we identify migraine? Okay, so take a mnemonic, which has been given in most journals, that is POUND. So remember POUND, that is pulsatile headache, 1 day duration, that is 4 to 72 hours duration, unilateral location, may be accompanied by nausea or vomiting, and most importantly, it's disabling. It disables the person or the person who is suffering. So if you have these characters, be sure it's a migraine headache. So what happens to a migraine patient? If you see a migraine patient, even if he comes to a doctor, more often than not, he himself diagnoses it as some eye problem. And then he says he goes to the eye specialist. Sometimes he feels, no, it may be some ear problem or some toothache. He goes to a dentist. He goes to a ear specialist. Last but not the least, he goes for his neck pain to an orthopedician, but he goes to a medicine specialist or a primary care physician in the end. And do you know, the last person to visit or the last person he will visit is a neurologist. Okay. So the neurologist comes last in the list. Why? Usually it is all these physicians, all these doctors who first see a migraine patient. The ENT person first says it is sinusitis, does some sinus wash. Dentist, he thinks it's some dental pain. Ophthalmologist prescribes glasses. So, the orthopedician thinks it's some neck pain, something to do with the cervical spine, does cervical MRI, everything is done. And last person he comes to is the neurologist. So that is how frustrated and how the life of a migraine patient goes on. Okay, so always it is imperative that we educate our primary care physicians to not only diagnose migraine, understand the signs, but treat it at their level, so that the primary part is done by them. Only those cases which require referral to a higher or super specialist is referred to a neurologist. So unnecessarily they are not harassed. So what do? You suspect migraine. So for suspecting, you have to look for sensitivity to light and sound, unilateral location, stomach uneasiness, pulsatile or throbbing headache, episodic headache, compromised quality of life, and look for triggers. And what is important is, do not miss out red flags, which is known as SNOOP, S-N-O-O-P. That is, if a patient has systemic symptoms like fever, weight loss, or HIV, cancer, or neurologic symptoms, abnormal neurologic signs, onset is very sudden or abrupt, especially older age group, and with a previous history of headache, be sure it is a secondary headache, the 10% which I told you, not the 90% of primary headache. So look for secondary symptoms, all these SNOOP signs. Just to brief you, you know this, the classic phases of migraine, that is aura. Before the aura, there may be premonitory symptoms, mood changes, swings, and the headache comes after the aura. Usually the aura is present when there is migraine with aura. Headache may be present without aura, that is known as migraine without aura. I recommend you see the ICHD3 beta classification. And once the headache resolves, there's a post-drome phase. So this is how it progresses over time. And this phase of migraine may take over 2 to 3 days and may extend to over 4 to 5 days. So this brings about a morbidity in the patient's life. Okay. Classification, I won't go into it. Just remember that migraine with and without aura, there are complications of migraine, childhood syndromes, retinal migraine, and probable migraine. Not to mention the vestibular migraine. We won't be discussing those things. We'll only be discussing our classic migraine, that is migraine with and without aura. So migraine with aura constitutes the classic one, that is the typical aura with migraine headache. The atypical one, where there is aura without the headache. Then there is aura with non-migrainous headache, familial hemiplegic migraine. Then there is the bacillar type of migraine and hemiplegic migraine. So what do you mean by an aura? So aura may take the form of visual aura. Usually it's the visual aura. It's not the auditory aura, which is seen in epilepsy. It may be a scintillating scotoma. You may see zigzag patterns, or it may be a central scotoma. You may not be able to see the central field of vision. And this usually occurs for a time being. You may see fluffy specks, that is multiple spotty scotoma, or you may have a hemivisual field loss. This migraine without aura, the management is a little bit different. Here, the headache lasts for 4 to 72 hours and should have at least 2 characters: unilateral location, pulsating quality, moderate to severe intensity, and may be associated with nausea, vomiting, photophonophobia, and at least 5 attacks within a month to fulfill these criteria. So all of you know about the diagnosis part. I won't go into the details. Some childhood syndromes, which you all should know, like the cyclic vomiting, benign paroxysmal vertigo of childhood, and abdominal migraine. Complications, you should be knowing. I won't go into the clinicals this time. So status migrainosus, migraine triggered scissors or migralepsy, which is known, and chronic migraine. These are complications. Triggers of migraine are very important. You all should know what are the triggers. Triggers are those which precipitate a migraine attack. They may be related to the weather, hot weather, sunny weather, or a cold weather, or even rainy season. Diet is very important as a trigger. High altitude, alcohol, smoking, drugs, and bright light. Coming to the food items, there are a lot of food items and triggers are specific for migraineurs. For each migraineur, the trigger may be different. For some, it may be chocolates, cocoa. For some, it may be caffeine. For some, it may be pickles. For some, it may be onions, beans. For some, it may be peanuts, butter, red wine, alcohol. And even for some, it may be monosodium glutamate used in Chinese preparations. There are mental stressors like anger, depression, anxiety, fear, which may trigger migraine, and change in the cycles, especially for women. And also when our biologic clock is overworked, we are oversleeping or we are not sleeping, working late hours, we are skipping meals, then we are bound to get migraine. And some things are specific for our Indians. Joint family stress, traveling in crowded trains in Mumbai, fasting in religious practices, hot climate, high pollution, educational stress, so on and so forth. Henna application in women, incense sticks. So all these may cause migraine. These are triggers. Now, how do you approach your case? So the best way to approach your patient is ask them to maintain a headache diary. Okay. So if the patient maintains a headache diary, he's bound to come back to you with a systematic maintain of the record of how many days he has had headache. So this will help you stratify whether the patient has a low grade of migraine or a low need of prophylaxis or a moderate need or a high need. Depending on the headache diary, you can do a MIDAS score. Okay. So depending on this MIDAS score, it's 0 to 5, 6 to 10, or an 11 plus. You can grade it as a moderately severe or a very severe migraine. So I won't go into the MIDAS questionnaire. You can see it on the net, or you can see it, download it from Google. So depending on the pain intensity and disability, we'll quickly go on to the therapeutics. It is usually seen that less than 10% have mild forms of headache. Mostly 40% have severe impairment, some impairment, and severe impairment is seen in almost 53% of the patients. So together, if you add, almost 90% will be having moderate to severe amount of headache, while mild headache is seen in 10%. So now you know that this is 80 to 90% of the patients who report to you will be requiring some form of therapy. because those who do not require therapy, they usually take over-the-counter treatment. They don't come to you. So now coming to the basic part, migraine treatment. Now, why I chose this topic is not only to highlight some of the recent advances which have come up in migraine therapy, but also to let you know that whether the old therapy which we are having is still golden therapy. So now we come to the migraine treatment, but before that, I'll show you a video
about how the nervous system
the pathophysiology.
If
Let
we
me
look at
just
what we
brief
think
you
of
about
as
the
a nerve,
pathophysiology
we see
within
how
5
it is
minutes.
made up of a bundle of similar neurons. Each individual neuron has a cell body with long extensions. When specialized sensors are stimulated, an electrical message starts on its way to the brain. But it is actually the flow of the charged sodium ions into the cell through ion channels, followed by the passing of potassium through separate ion channels out of the cell, that generates the electrical signal. An electrical wave then moves rapidly towards the brain. At some point, each neuron reaches its limit, and the signal must be transferred to the next set of neurons. Here, calcium channels open and secondarily cause the release of chemicals called neurotransmitters into the synapses, where receptors on the adjacent neurons must detect the neurotransmitters and regenerate the electrical signal. It is during this complex process that mistakes can be made. Think of a genetic defect as a mixed-up message about how the cell is to make things. For example, one of the known genetic defects of migraine is one where the cell is instructed to produce a protein that cannot fold into its normal three-dimensional shape. When positioned in the cell membrane and an electric signal comes along, the defective protein may open up and let calcium ions into the cell, but it might not be able to snap back into a fully closed position, allowing too much of the electrically charged calcium into the neuron. In this case, the neuron would keep releasing neurotransmitters, and the next cell would generate an exaggerated response. The consequence is that the neuron has overreacted to a stimulus. This is not just theoretical. There are known genetic defects of ion channels in families who suffer from migraine. Additionally, research has revealed genetic mistakes affecting how neurotransmitters are made, released, and inactivated. Therefore, each individual inherits a mixture of genetic errors. This may partly explain the broad spectrum of migraine symptoms and how, between individuals, migraine might affect a lot of different parts of the nervous system, not just the pain pathways. To illustrate this, let's look at the trigeminal nerve. This nerve has branches that innervate facial muscles, temporal mandibular joint, paranasal sinuses, and teeth. When stimulated, branches of the trigeminal nerve transmit information back to the brain through the trigeminal nucleus in the brainstem. From here, this message is sent to other parts of the conscious brain that acknowledge the pain and the need for action. But for a migraine sufferer, the threshold for initiating this distress signal is lower than normal, and the amplitude of the warning is abnormally high. Cortical spreading depression. So what causes the intense headache of migraine? The current theory is that a trigger, either in the brainstem or in periphery, sets off an abnormal electrical event called a cortical spreading depression. This is a wave of electrical activity that sweeps slowly across the surface of the cortex. A cortical spreading depression first initiates flashing lights or abnormal smells, followed by an intense headache. The electrical depolarization results in a release of neurotransmitters and other molecules that cause secondary inflammation. A person then experiences light sensitivity, nausea, foggy thinking, and fatigue for hours. By mechanisms that are still to be defined, the chemical reactions of a cortical spreading depression appear to affect the dura, where blood vessels dilate and contract. Mast cells release their potent inflammatory chemicals, and trigeminal nerve fibers send signals back to the brainstem. While cortical spreading depressions cannot explain many of the symptoms of migraine disease, it is likely an important event in generating the most familiar, brief, intense experiences of migraine sufferers. Migraine has a chronic form, central sensitization. It has been observed that migraine sufferers have scarring within the brain. This may be a complication from the repeated inflammation associated with cortical spreading depressions or other migraine events within the brain. Eventually, parts of the damaged nervous system simply generate low-grade, frequent, unwelcome symptoms, such as increased sensitivity to touch or light, daily headaches, tinnitus, or diminished cognitive functions. Central sensitization partly explains why migraine sufferers have different symptoms at different stages in their lives. Also, the damage to blood vessels from inflammation may explain the higher rates of stroke in migraine sufferers. And head trauma to the hypersensitive central nervous system may make migraine sufferers more vulnerable to chronic headache syndromes. The brainstem may be the core of migraine disease. Another factor in migraine disease is that abnormal electrical activity of one set of neurons may affect the behavior of adjacent ones. The brainstem is the crossroads of much of our brain circuitry. It is here that information controlling many body functions congregates in clusters of cell bodies called nuclei. When electrical messages arrive in one nucleus, they may be rerouted to other parts of the brainstem, hypothalamus, thalamus, and cortex. These nerve centers have exotic names such as the trigeminal nucleus, pulvinar, dorsal raphe, and locus coeruleus.
So basically, the pathophysiology is inflammation leading to abnormal sensitization of the trigeminal pathway. And as we saw in the video, we saw that the brainstem also plays a role. And this has also been highlighted in PET studies. If you see, the brainstem shows signals, hotspots in the PET study. But now recent studies have focused on CGRP, or the calcitonin gene related peptide, which is a neuropeptide which is involved in inflammation in and around the trigeminal nerve ending. And it has been the target of recent research, and CGRP antagonists, receptor antagonists, are the molecules which are the current hot topics of research, and they are the new things in migraine which are coming up. So, a little bit about the pathophysiology, and now we come to the strategies for migraine treatment. So basically, how we treat a migraine patient. So first thing is we have to give preemptive therapy. Preemptive means we have to educate the patient that this is the pathophysiology of the disease. You need to limit your triggers and you need to maintain a healthy lifestyle. It is more so of a lifestyle disease. We have to stop and elevate the pain. So we need to give some acute treatment. We need to prevent further progression and further recurrence of the disease. So we need to give preventive treatment. So these are the three stages or strategies for migraine treatment. And it is crucial that for prevention, we give them educational programs. We ask them to monitor the attacks. We ask them for evaluation, regular evaluation, and non-pharmacologic strategies, which we will discuss. Pharmacology is very important in terms of acute and chronic therapy. For chronic therapy, we also require some ancillary therapy like relaxation, biofeedback, CBT, and we have to look at the patient's expectation and the cost of therapy. So you have to take into account what your patient wants. They not only want an effective acute treatment for the headache. Nobody wants to stay with the headache for a long time. So if you tell that wait patiently, the headache will come down in 2 or 3 days or 5 days or 10 days, they will go to the next doctor. They will leave you. So that is what happens. They usually switch doctors because they don't have faith in one doctor. Now, They want complete freedom from pain. It is not that you give them partial pain relief and they are very happy. And they want rapid onset of action. Everybody wants everything rapidly these days. They don't want to wait. Everything should be done rapidly. Everything in one day, everything rapidly. Everybody wants as fast as possible. So that is the state of action now. And absence of adverse effects. So we want not only the good things, but we do not want anything bad about things. So the first thing you give them the drug, they not only want complete relief, they want as relief as fast as possible. They will ask you, doctor, there is no side effect, no? And it should not reoccur. That means you are giving them some jadi booty so that once you are giving, there should not be a reoccurrence for lifelong. So that is what the patient wants, but be realistic. Tell them what is the real goal. You will give them acute treatment. It will relieve them of the headache, but it will give them relief from pain. But tell them that these are bound to reoccur. There may be some side effects. So explain to them. That is very important. Now coming to the acute treatment of migraine. Now acute treatment is classified into those treatment which are class 1 recommendations or which are very important and you can give as a class A, and rest of the drugs which are class A but you may or may not give. So among them are the triptans and dihydroergotamine which are usually used, and the second line are the NSAIDs or the analgesics, which include acetaminophen, aspirin, along with caffeine. And you can use other drugs like ibuprofen, naproxen, and other intranasal preparations, butorphanol, which we shall discuss as our lectures progress. Now, acute migraine medications, as I discussed, will be specific class 1, that is ergotamine, dihydroergotamine, and triptans. They are specific for migraine. Then there are non-specific drugs which have other side effects, that is NSAIDs, analgesics, opioids, neuroleptics, antiemetics, and corticosteroids. So the goal of acute treatment is to treat very early in the attack, use correct dose and formulation, don't undertreat, use for a maximum of 2 to 3 days per week, because one attack will last maximum for 2 to 3 days, not more. Stratified treatment, I'll tell you what is stratifying treatment, and make use of the best approach. Okay, this is the best approach when attacks are infrequent. Just give acute treatment once a month, or maybe once in 2 months. Patient says once in 6 months, give only acute treatment, no prevention. Where compliance is a problem, give only acute treatment. So there are 2 methods of acute treatment. One is a stepwise care, which you use in the olden days, but now some physicians are using. You go from A to B to C. That means you give the patient drug A, you tell him to take it during acute headache. So he will take it for 2-3 months. Whenever he's having acute attack, he's not relieved. Remember, the patient may have attacks which vary in intensity over day, maybe depending on the stressor level, depending on the triggers. So you don't know how intense will be one attack from the other. So if you give just one drug as a broad spectrum acute treatment for all attacks, it is more likely that the drug may work for some attacks, it may not work for other attacks. Hence came the stratified care, where you take the patient's requirements into consideration. That means you give him options, you give him 2 or 3 drugs for acute care. That means if he has a mild attack, you ask him to take drug A. It may be a triptan, it may be a sublingual preparation of a triptan. Then if he has a severe attack, you tell him take a triptan plus NSAID or only NSAID. And if he has a very severe attack, tell him you can take an injectable. Also mention that in the prescription. And if he has some nausea and vomiting, give him another antiemetic with it so that it tailors to the patient's requirement. So he has more faith on you. He comes back to you. And whenever his acute care is managed, his headache is managed properly in a stratified way, he will come back to you. He will tell, no, doctor, I had these attacks. I wrote it in the diary. And for this, I took this much of triptans. For this, I took analgesics. For this, I took injectables. So you know actually how much severe headache he's having, how much Midas he's having per month, disability he's having. So initially, you give him a therapy, back it up with another therapy that is for acute attack. If he's not responding to the initial therapy, and if the backup therapy also fails, on the follow-up visit, go for a rescue therapy. But rescue therapy should work only with the help of a prophylaxis, because it is high time that the patient may be requiring prophylaxis, or you have to monitor whether he has some other comorbidities or he's not taking the drug properly. So this is the basis of stratification. You know, if the headache is severe at onset, the patient will know himself. Then you go straight from A, you don't go to A, you go to B. Symptom profile, nausea and vomiting are very much, then go for parenteral therapy. Headache is frequent, there is chance of medication overuse, require prophylaxis. Adverse effects are more, then switch the class of drugs. So this is the acute migraine treatment, the analgesics, which I've already told you. These are class A recommendation. Some analgesics are class B. I won't go into the details, but you can try all these drugs according to your availability and according to your patient suitability. Antiemetics, again, you can add on depending on whether the patient has nausea and vomiting. Safer is domperidone. It has no extrapyramidal side effects. But the class of drugs which we are more interested in is the triptans. The triptans are coming up in a big way. They have innumerable methods of drug delivery: subcutaneous, intranasal, peroral, sublingual. So there are a lot of ways of drug delivery. Sumatriptan is the prototype which we use rampantly, but you have other mechanism of action, modes of delivery, like zolmitriptan, nasal spray. You have rizatriptan, you have preparation, sublingual, oral mouth dissolving preparations. Almotriptan you can give to kids. Kids can take almotriptan. So all these triptans, they work through the 5-HT receptor antagonism, 1B receptor antagonism, and cause vasoconstriction. But be very careful. If they have cardiac comorbidity, they cannot take these drugs. Be very careful in giving. And this is the list of all the triptans approved. Sumatriptan is the prototype, but now you have a lot of drugs coming into the market. Rizatriptan, Zolmi already in the market. Almo is already in the market. Frova and Nara not available in India, but you will get it within a few days. So the formulations which work better or earlier are the sublingual preparation followed by tablet, and intranasal followed by IM or subcute. And if patient is in status migrainosus, always go for IV. Now for acute management, you always treat the headache early, use adjunctive therapy if required, try dihydroergotamine, and go for preventives. Always see for aggravating medications. Now we go on to the preventive part. Now prevention is again four-pronged. You go for trigger avoidance, go for oral or injectable agents, go for natural measures, which will go last, and neuromodulatory devices. So before you start prophylaxis, remember START, S-T-A-R-T. If the patient suffers 2 or more attacks, Attacks are very severe. Attacks do not respond to adequate acute drug management and relief medications. And there are comorbid conditions like status migrainosus, hemiplegic migraine. It's time to start prophylaxis. What factors influence? Always look for patient preference and coexisting conditions. I'll tell you the coexisting conditions. Migraine type, here the migraine type is very important, and adverse effect profile you have to take care. So you have to select the right drug for the right patient. It differs from patient to patient. And you have to give an adequate trial, at least give for 4 to 8 weeks before you switch over the drug. And educate your patient that this is a prophylaxis, this is a preventive. It will take time to work. So what are the drug classes available with us? We have beta blockers, calcium channel blockers, we have tricyclics, and the anti-epileptics. So drugs which have proven efficacy, these are the 4 groups which I've already told. Then there are some drugs which do not have, which are probably effective. Now, atenolol, nadolol, NSAID, cyproheptadine, magnesium, and riboflavin are coming up with possible efficacy. These are the drugs with possible efficacy: clonidine, verapamil, nicardipine, nimodipine, but they have not been proven. Now, how to choose your drug, right drug? So if you are choosing flunarizine, be sure that thus are the comorbidities: complicated aura or a hemiplegic migraine, patient has depression or Parkinson's disease are contraindications. If you are using propranolol, patient has some anxiety or hypertension, but he should not have asthma or diabetes. Topiramate used in an obese female should be very happy. If epilepsy is a comorbidity, use topiramate, but don't use in renal insufficiency or angle closure glaucoma. And divalproate, it's a good drug in depression and epilepsy. Amitriptyline used in depression and neuropathic pain with sleep disturbances. So these are the prototype anti-epileptics which we commonly use, and these are some of the side effects which we I've already told you. These are the second choice drugs. Venlafaxine is coming up in a big way for migraine prophylaxis, pizotifen and bisoprolol again. Now, third choice drugs, among them magnesium and riboflavin are coming up. Coenzyme Q10 is again a drug to look out for. So how long do you treat with prophylaxis? Ideally, you should start with one prophylaxis for one patient, and that should be perfect. For an obese patient, female, use topiramate if there are no other contraindications. If the migraine is acute, disabling, and there is some depression, use divalproate. If it is a mild attack, some anxiety, palpitation, use propranolol or flunarizine. For kids, you can go for either flunarizine or topiramate, but use it for a fair amount of time. 2 to 6 months is adequate. You can continue therapy for at least 1 year, but you should get effect by 3 months. 50% should decrease the headache frequency by 3 months. If it is not happening, switch over. There is very little chance of combination therapy, but combination therapy is recommended provided it is rational. You use one anti-epileptic with one mood elevator, or you use one anti-epileptic with a beta blocker or a calcium channel blocker. Onabotulinum toxin type A is used as a rescue therapy and also for chronic migraine. So the dose as seen by the preempt trials was 155 units. And these are the sites where you give onabotulinum toxin. It's a wonderful agent if you have used, and it usually makes the patient amenable to therapy, especially chronic migraine not responding, those who have MOH. And now coming to the newer drugs. Over the last 10 years, there are 3 groups of drugs which are being developed for migraine. From 2000 on, research has been going into the GPANTs, that is the calcitonin gene-related peptide receptor antagonists, anti-CGRP monoclonal antibodies, and the DITANs, that is the 5-HT1F receptor antagonists. So as we all know that the CGRP is the neuropeptide to target for both acute as well as chronic migraine. And let's see how CGRP has been targeted. All these CGRP receptor antagonists, they directly bind to the CGRP receptor and they halt the neuroinflammatory process, and they reduce the propensity of acute attacks and also the chronicity of attacks. But now more specific CGRP receptor antibodies or CGRP antibodies have come up, of which eptinezumab, fremonizumab, and galcanezumab are anti-CGRP antibodies. They work on the CGRP, whereas the anti-PAC1 receptor antibodies, they work on the PAC1 receptor. So these are two groups of receptor antibodies. So basically, there are receptor antagonists and the antibodies. So first, coming to the antagonists. So a lot of drugs were developed, first atogepant and olcegepant, but their development was terminated due to hepatotoxicity. But rimegepant and ubrogepant were approved by US FDA, and these are oral drugs. And as you know, these are HT receptor antagonists. They work just like triptans, but they are safer. They don't cause vasoconstriction, and their cardiac safety is very good. They work without causing vasoconstriction, without cardiac comorbidity, given safely for acute migraine. So see, the dose 75 milligram is for rimegepant and 50 to 100 milligram is for ubrogepant in ACHIEVE 1 and 2 trials. And they have very good response, especially at 2 hours pain freedom is very good for these oral drugs. They are now both in the market. And now coming to the monoclonal antibodies, we have 3 humanized monoclonal antibodies, that is eptinezumab, galcanezumab, and fremonizumab. But erenumab, that is the fully human antibody, that is the CGRP receptor binding antibody, that has come into the market. And these all other trials, there's a busy slide, I won't go into the details, but all these trials show that these are injectable drugs and they are given at intervals of maybe 4 weeks, 12 weeks, and usually they are all FDA approved. They are phase 3 completed and they will be in the market within a few days. Already they have been completing human trials, and erenumab is almost in the market. So coming to summarizing the CGRP inhibitors, already we have 3 erenumab, fremonizumab, and galcanezumab, which require once a month dosing, and eptinezumab, which is an IV infusion, and ubro and rimegepant are oral drugs. They have some side effects, but they are not very toxic. And now we have literature where they have been given CGRP receptor antagonists, injectable for chronicity, chronic migraine, plus monoclonal antibody rimegepant for oral therapy for acute migraine. So now you have a new combination for acute and chronic migraine, which was unheard of way back. Now comes the 5-HT1F receptor antibodies, that is the DITANs. So the DITANs are those which do not have a vasoconstrictive effect. And these drugs are not contraindicated in migraine patients with coexisting cardiovascular complications or cardiovascular diseases. And the prototype drug is lasmiditan. It has a very high affinity for 5-HT1D, and it acts for both acute as well as chronic migraine. high CNS penetration, and it has been seen to have a very good 2 hours pain freedom in phase 3 trials. Both Samurai and Spartan showed that in doses of incremental doses of 100 to 200 milligram, it had very good headache reduction. So, but guidelines still do not recommend these drugs. So kindly, if you are a headache specialist or you are a neurologist, practicing neurologist, use these drugs, but don't use it unless you are very much familiar with their mechanism of action. So what is the update? What is the American Academy of Neurology recommendation? So all these anti-epileptics, beta blockers have a level A recommendation. Even triptans have a level of recommendation. The rest of the drugs have a level B recommendation. Okay. And some other drugs have level C recommendation. Now we come to the newer therapies, that is the neuromodulation. These are coming up in India, and these will be helpful in the long term. And so transcranial magnetic stimulation. This is one device which is very good device, transcranial magnetic stimulation. There are two mechanisms where it stimulates the brain and it reduces the propensity of inflammation of the trigeminal pathways. ONSTIM is the occipital nerve stimulation device, and KEFALI is the supraorbital stimulation device. So these stimulation devices these are external devices, these are very good, user-friendly, and they reduce the intensity of acute attack and terminate the acute attack. This is the Serena on the left side of your picture. This is a single pulse transcranial magnetic stimulation device used on the back of your head. This is marketed by the eNeuro Therapeutics. And Gamma Core is a vagal nerve stimulation device. These are usually marketed in European markets. And now we also have a small handheld device that is the transcranial magnetic stimulation device, which is being marketed by eNeuro Therapeutics. Last but not the least, there is role of riboflavin, which is a class B recommendation in several trials, and dose starts from 200 BD, 400 up to as high as 600 milligram. And it is for prophylaxis or prevention of migraine. And not only that, oral magnesium, coenzyme Q10, and B12 have been seen to result in migraine prophylaxis. I have given them, and we are very sure that these have a positive effect on migraine prophylaxis. Still to come are newer drugs in the pipeline, tezepamel, filorexant, and ADX, nitric oxide synthase inhibitors. So these are yet to come, but prevention is better than cure. Always remember, you should remove triggers. You have to maintain a regularity in everything. Eliminate everything that is too fast, too sudden, too much of everything, that is too much of food, too much of sleep, too much of stress. Regular day-night rhythm. Stabilize energy metabolism. Have good nutrition. Do not miss breakfast. Eat slowly. Hydrate yourself. Either regular coffee or no coffee. And most importantly, get adequate rest, sleep, take a lot of vegetables, exercise, and take care of your near and dear ones, especially in pregnancy. So it is important that patients take care of themselves. You take their voice when you are planning a treatment for them. Consider comorbidities. Always start low, go slow, educate them. Education is very important. And when you take your patient into confidence and go for therapy, preventive therapy, explain to them, they will be more amenable to it. And last but not the least, old is still gold. We are still with the old drugs, but the future is bright. We will have newer drugs in the horizon, which are going to take up the market, and also which will give us the impetus to do more research in the future. So these are some of my memories from Australia, where I did my fellowship on headache at the International Headache Society, and Professor Gagandeep awarding me the Iron Travel Grant in 2018. So thank you all for your attention. I end my talk.
Thank you. And we have a few questions.
Yeah, I'll be happy to take on.
Yeah. Dipanjali Sahu from Jajapur, he says he has got a sinus problem and headaches. How should he cure his sinus problem?
So, ma'am, first thing I would like to highlight is you have to be very clear whether it is sinus or whether it is migraine. As I reiterated in my slide, you have to show a doctor first, and you have to be very clear whether it's a recurring problem and it is disabling you, it has a disabling intensity, and if the headache is recurring, it is disabling, it's unilateral, throbbing, and it reoccurs every month, and it may be associated with some nausea and vomiting, more likely it's migraine. So be very careful whether you label it as sinus or migraine, and then only we can think of planning your management.
The next question is Shrabani Sahu from Jharsuguda. She suffers from headache at regular intervals, especially after traveling or keeping a fast. So can you suggest some remedies for this?
Yeah, so I think she has migraine, and the first thing I would say is because she has known her triggers, that is fasting and after doing some activity, so she has to take care to avoid certain triggers which are causing headache. So once she starts avoiding her triggers, she's going to get some relief, and she can take acute medicines. Like she can take some triptans if it is available at Jharsuguda, or she can take simple analgesics like naproxen with domperidone for acute management. But better she shows some doctor if it is recurring and it is on regular interval. And I would also suggest that she maintain a good healthy lifestyle, good food, regularity in her timings, adequate nutritious diet, and hydration.
Rupali from Faridabad asks, how do we get a complete cure for migraine?
Well, you have to fight it. You don't cure it, because migraine is a lifestyle disease. So if you maintain a good lifestyle, it is not going to reoccur. But if you maintain an unhealthy lifestyle, it is going to remind you, because it's in your biologic clock. It's in the hypothalamus. I've already shown in the video that brainstem, some part of the cortex, hypothalamus, these are areas which stimulate the trigger. So you have to be very careful. You have to maintain a healthy lifestyle if you want to avoid taking medications. So avoid triggers and avoid stress as far as possible. Do some regular exercise, yoga, if music, if you are interested in, and try to avoid triggers. Hydrate yourself, and if required, take some acute medication or prophylaxis, but under your doctor's supervision.
S. Vinod Khanna from Chennai, what is the duration of migraine treatment?
Yeah, actually, I showed that usually, if it is mild headache and you are going for acute treatment, you just take during those 2 or 3 days when you have an acute attack. But if you are going for prophylaxis, you have to give adequate time for the drug to work. Usually, we allow a 3 months time for the drug to start working. And as I showed, it's a 3 to 6 months time the drug should be you should give adequate time for the drug to work. So ideally, it should be for 6 months for the drug to start working, and you can continue it up to 1 year. That is the prophylaxis. But this is only to give you time to adjust your lifestyle, to maintain a healthy lifestyle, and to bring about changes, regularity in your rhythm, and inculcate a good diet habit with adequate hydration, nutrition, and avoid triggers.
Dipukanta from Bhubaneswar, He says he's suffering from headache regularly. So is this migraine?
So as I've already reiterated, you have to see whether all these symptoms are there, as I've already reiterated, disabling intensity, unilaterality, throbbing, reoccurring. So if any of these features, two features, and it's regular, so it may be migraine. So if you are not very sure, consult your nearest doctor and you will get some form of advice and treatment, and I think you will find a solution for it.
Dr. AVS, a psychiatrist from Nizamabad, for how many weeks, months or years prophylaxis should be given if the attacks begin after stopping prophylaxis?
Yeah, so, usually what happens is, especially in female patients, there's a tendency that migraine can reoccur because they don't maintain a lifestyle change. And usually it follows this cyclical pattern, and this may go on for 40, for 50, and some with familial history may even go longer, 50 or 60. So usually what we do is we give a prophylaxis for 1 year, and we ask them to make some lifestyle changes. After that, we see that the patient is okay, and we slowly taper off the prophylaxis. And we tell them to continue maintaining the healthy lifestyle and do with acute medication SOS as and when required. But suppose the patient comes back to the current situation, or again requires prophylaxis, we can go for a longer prophylaxis. We can go for at least 2 years prophylaxis. So it depends till the patient wears off the migraine. That is the dictum.
He has another question. Which triptan has relatively lower side effects?
Yes, actually, whichever drug you use for acute treatment, be it triptans or analgesics, you should have a count on how many days you use. Triptans you do not use more than 15 days a month. So if you are using triptans more than 15 days a month, there are bound to be side effects. So that is the time where you give prophylaxis. And analgesics, try not to use more than 10 to 12 days a month. So if you are using these drugs more than that, you may develop medication overuse headache or MOH. So be very careful, keep a count, or do maintain a headache diary for your patients.
Dr. Avias also asks, with no comorbidities, which single drug would be the best for lifetime prophylaxis if required?
We don't give a lifetime prophylaxis. Actually, you should tailor it according to your patient. This is one area where you require expertise. You have to see your patient profile, how your patient will respond to what drug, what is the intensity of headache, what's the duration. It has to be tailored. It's not one drug that will be universal for all your patients. So suppose I have a young female who is having an acute, very severe headache, and she's lean and thin. So I would naturally, there's some component of depression, I'd naturally go for a divalproate for a short course. And if she later on requires, I may switch over to a safer drug. I mean to say beta blockers or calcium channel blockers. But all the while taking her into account, taking her into consideration, explaining to her the side effects. So you don't give a lifetime prophylaxis of drugs because you have to take into consideration the side effects. Anyway, you have to taper off and you have to stop the drug after a year or so.
Dr. Avias asks, what would be your choice of a triptan with relatively less side effects?
When I choose oral triptans, usually rizatriptan is plentifully available, and usually the oral preparation and mouth dissolving preparation, tabs and sublingual preparation is available. So rizatriptan is a very good drug. Patients with mild to moderate severe headaches, they do respond to rizatriptan. But when you are going for a combination with analgesic for severe headache, a patient not responding to only triptans, you go for sumatriptan.
Dr. Avius also asks, are there any specific blood tests to be done for long-term prophylaxis?
No, I don't think you require any blood test for prophylaxis. Only thing, if you have any comorbid condition, you must rule out. You must look for any vitamin deficiencies. You have to rule out thyroid conditions, any blood-related conditions, so sugar and all. So you have to rule out only comorbid conditions, not for migraine. LFT and all you have to monitor if you are giving this valproate and all.
Dr. Vibhu Datta from Bhubaneswar, what is the first line of drugs you would prescribe for prevention in your practice?
I use all the first line drugs for prevention. So it's not that I use one drug. So I give all the drugs available depending on the patient profile. So commonly we use beta blockers and this flunarizine calcium channel blockers, but we rampantly use valproate. Our studies going to get published recently, we have done on more than 500 patients. It is already cleared and into print. I did not show my study, but we used valproate as the most common prophylaxis, and we have also used propranolol as the second drug. So that study you will see within a few days.
Okay. Santosh, there's one question from Dr. Manish from Pune. He asks, Amnurite was with Centaur, so how is it with your new company?
I will answer this question.
Yes, Mr. Nayak.
Amnurite was always a brand of health and youth therapeutics. It remains a brand of health and youth therapeutics. In the initial period, we used Centaur as a distribution company to distribute the product. But it was launched as Health and You brand and remains Health and You brand. Now Health and You distributes Amnurite on their own with their own medical representative and distribution channel. Thank you.
Thank you. Thank you, Dr. Nayak, for this lucid presentation.
Yeah.
Yes, sir. So I would like to thank you all the audience for joining this webinar on the migraine. And I'm very happy to share that 204 doctors are logged in for today's webinar. And we had more than 20 questions in our question box. Special thanks to Dr. Manjusha Madam for his wonderful coordination for this webinar. And I request all the audience for innovative all the health and therapeutics products. That is Amnurite, AmnuriteBeta. Now we have launched Brentamin also. So this webinar will be available on our DigiNeuro channel. Tomorrow we'll upload it on DigiNeuro channel. So I request just subscribe our channel so you will get the update from our DigiNeuro channel. So here all the therapy, including the vertigo, epilepsy and migraine, all the webinar is available over there. And so once again, I would like to thank you, Dr. S D Nayak sir, for coming as a speaker and giving this brief talk on the migraine. Yes, sir. And with this, sir, just we are closing this webinar. Thank you, sir.
Thank you very much, doctor. Thank you so much. Fantastic presentation. A lot of take-homes for doctors today.
Okay, thank you. Thank you.
Thank you, sir.
Yeah.
Thank you, Dr. Manjusha, for coordinating.
Thank you, Santosh. Thank you, Deepak.
Thank
and
you.
thank you, Dr. Manish.
Thank you, sir. Thank you, sir.
Thank you.
Thank you so much, sir.